Ladies and gentlemen, you are most welcome for the topic of today, which would be vasculitis. And this is a very common topic in the MRCP with some high yield questions. I would be starting by definition. It's inflammation of the vessel's wall leading to thickening, occlusion, and subsequent ischemia. And it's classified according to the vessel wall as small vessel vasculitis, medium vessel vasculitis, and the large vessel vasculitis. So what about the small vessel? It could be granulomatous, it could be non-granulomatous. And in the granulomatous, we have the Wegener's granulomatosis and Church-Strauss disease. In non-granulomatous, we have the microscopic polyangiitis and Henoch-Schönlein purpura. So what is Henoch? Henoch usually involves the pediatrics group of patients and young adults, and it's characterized by deposition of immunoglobulin A in the blood vessels. And children usually present with a very characteristic rash that involves the shin. I would show you in a minute, with IgA showing in the vessel biopsy, arthritis, renal affection in the form of hematuria, polyuria. Sometimes they might present with abdominal pain, and this is usually preceded by like 2 weeks history of upper respiratory tract infection. This illustrates the very characteristic rash of Henoch-Schönlein purpura, which involves the shins of the legs. The second case is 63 years old lady presenting with shortness of breath, coughing up blood for 5 days with history of recent epistaxis, headache, unintentional loss of weight, purpuric rash of the lower limbs, arterial blood gases displaying a pH of 7.1, PCO2 of 4, and this is metabolic acidosis. So upper and lower respiratory tract infection with rash, metabolic acidosis, hemoptysis. SLE does not explain, Henoch-Schönlein purpura doesn't, and polyarthritis nodosa doesn't. It's only the good pastures and Wegener's that can affect the lungs and the kidney, leading to acidemia. So in this one, the differentiating point would be two. It would be the epistaxis, and if the patient doesn't have any renal affection, then also the acidemia characterizes the Wegener's granulomatosis. So this is Wegener's granulomatosis based on the metabolic acidosis and the epistaxis, which differentiates it from the other types of vasculitides. So we come to the next one, 70 years old, Wegener's granulomatosis on monthly intravenous cyclophosphamide and prednisolone for the last 6 months. The patient was well controlled, all routines were normal, and they are going to start him on azathioprine. So what screening test should be done? Is it the blood level for thioprine methyltransferase, or the chest x-ray, or serum urate, or sperm count? So this question is displaying your knowledge. You are going to be checked on your knowledge regarding the thiopurine methyltransferase, which needs really to be screened for before starting azathioprine, because it has been shown that 89% of the individuals of the populations all over the world has got this thiopurine methyltransferase as normal level, while 11% are deficient. So those who are deficient are much more prone to develop myelosuppression when they are given azathioprine. So before giving azathioprine, we have to screen for this enzyme, which is known as thiopurine methyltransferase. What about the medium vessel vasculitis? This includes Kawasaki disease, polyarthritis nodosa, Berger's disease, and I'm going to show you in the next slides some of them. So this is polyarthritis nodosa affecting the flexural surface of the legs. This is Berger's disease leading to dry gangrenes of the toes and of the tips of the fingers over here. So this is a 45 years old female with chronic joint pains, recent painful purpuric rash. It's bilateral and involving both ankles. So this is stomach disease with arthritis. It could be SLE, but he's telling you that's negative anti-nuclear factor antibodies, which is almost 100% positive in patients with SLE, negative P ANCA, and this is usually done for polyarthritis nodosa, and positive in 60% of cases. So 40% could be negative and still they can have the disease. Rheumatoid factor, sometimes it's just falsely positive in patients with vasculitis, and this patient has got positive hepatitis B surface antigen. So if you find positive hepatitis B or C in a patient with vasculitic lesion, this points to diagnosis polyarthritis nodosa. So this is a case of polyarthritis nodosa with hepatitis B surface antigen positive. So we come to the large vessel vasculitis, and those are two types: Takayasu arthritis and temporal arthritis. Takayasu is usually common in Japanese, but the temporal arthritis is worldwide known disease, and it affects elderly people. Usually they would come with severe headache, and temporal artery area might be very much painful and tender to touch, and the temporal artery might be feeble or even occluded completely with no pulsations. In those patients, if you suspect, you go ahead and treat. Usually their ESR is high, but even if you cannot do a single investigation, you go ahead and treat those patients with high dose prednisolone and then send them for a biopsy that might confirm the diagnosis. But on clinical grounds, you can treat the patient to save his vision. They are very much prone to develop blindness. Other types: this is a 50-year-old man presented with left popliteal deep vein thrombosis and recurrent oral and genital ulcers, iritis. So what's the diagnosis? I would like to tell you here that any male patient in whom you find deep vein thrombosis, if you cannot have it being provoked by something, they are usually Behçet's disease. This syndrome is well known to affect male, and it's characterized by arthralgia, arthritis, iritis, sometimes urethritis, and they can have deep vein thrombosis. In writers is a triad of arthritis, uveitis, and urethritis. So there would be no deep vein thrombosis in writers. This is the differentiating point. So other types, like Goodpasture syndrome, this is the antiglomerular basement membrane. It affects both the lung and the kidneys, as we have mentioned earlier, but it doesn't affect the upper respiratory tract, and this is the differentiating point between it and Wegener syndrome. In addition, the antiglomerular basement membrane antibody would be positive in those patients. As we have mentioned about Behçet's, and the treatment would be steroids. Kawasaki usually occurs in children and young adults. There is desquamation rash of the palms and the mucous membranes. They might have low-grade fever with lymphadenopathy, and this is the desquamation that might be as severe as this. Sometimes it's very mild that you cannot identify unless you look purposefully for it. And this is again Kawasaki with reddish eyes and inflamed cheeks, with desquamation rash on the cheeks this time. This is desquamation rash on the dorsums of the feet. And this is a patient with Kawasaki who presented with coronary artery disease. This is medium-sized arteries. And look at this, there is aneurysmal dilatations on coronary angiography. This is very characteristic of Kawasaki. They might present with acute myocardial infarction. Vasculitides might be secondary, like in patients with systemic lupus, dermatomyositis, hepatitis B and C viruses, and certain drugs like hydralazine, allopurinol, penicillins, propylthiouracil, which is used in the States for pregnant thyrotoxic ladies, cephalosporins, and immunomodulators. What investigations should we do? Antinuclear factor antibody. Almost it rules out SLE if it's negative. The P ANCA, as we have mentioned, it's present highly positive in microscopic polyangiitis and Wegener's. The C ANCA, usually also in Wegener's. Antiglomerular basement membrane antibodies in Goodpasture syndrome. By this, we come up to the end of this lecture. See you in the next lecture. Thank you very much.